Hello everyone. Thank you for joining me today. My name is Docsaab and I am excited to present on the model for end-stage liver disease or MELD score, a cornerstone in hepatology and transplant medicine. In this overview, we will explore how the MELD score assesses the severity of liver disease, predicts patient outcomes and guides the equitable allocation of donor organs. By the end, you will have a clear understanding of its definition, components, history, applications, and interpretation. Let's dive in. Let's start with the basics. What exactly is the MELD score? It stands for Model for End-Stage Liver Disease, a numerical scoring system developed to evaluate the severity of chronic liver disease. Its core purpose is to predict a patient's survival over the next 3 months, helping clinician gauge how urgently intervention is needed. The score ranges from 6 to 40, where lower score indicates milder disease and better prognosis, while the higher score signals severe dysfunction and elevated mortality risk up to 71% in extreme cases. For application, MELD is the gold standard for prioritizing liver transplant candidates aged over 12 and older. Younger children use the similar MELD score. Interestingly, it is originated in the late 1990s at the Mayo Clinic, initially designed to forecast mortality risk during TIPS procedure for portal hypertension. Its accuracy led to its broader adoption in the transplant allocation by 2002. This evolution underscores MELD's role as an objective, data-driven tool in saving lives. Now, how do we arrive at MELD score? It based on three key lab values that reflect liver and kidney function plus clotting ability. Serum creatinine in milligram per deciliter, which indicates kidney impairment, often tied to liver failure. Serum bilirubin in milligram per deciliter, a marker of the liver's inability to process waste. And the international normalized ratio, measuring blood clotting time. The calculation uses a logarithmic formula to weight this objectively. Importantly, any value below 1.0 is flowed at 1.0 to avoid mathematical errors. The original equation as shown is MELD is equal to 0.957 into log creatinine plus 0.378 into log bilirubin plus 1.120 into log INR plus 0.643 into 10 rounded to the nearest whole number. This formula ensures the score is reproducible and unbiased, relying solely on the routine blood test. Later versions like MELD NA add sodium for even better precision. The MELD score didn't emerge fully formed. It is the result of ongoing refinement. It began at the Mayo Clinic under Dr. Patrick Kamath as the Mayo End-Stage Liver Disease score in the early 2000s, focused on TIPS procedure risk. A pivotal moment came in 2002 when UNOS and OPTN replaced the subjective child turquoise Pew system with the MELD for liver allocation, prioritizing the sickest patient based on data. By 2016, it evolved into MELD NA with the addition of serum sodium, boosting its ability to predict the waitlist mortality by about 5% per sodium fluctuation. The current frontier is the MELD 3.0 rollout in the US in 2023, which incorporates patient sacks and recalibrated coefficients to address disparities and improve accuracy, potentially saving more lives through fairer prioritization. This timeline shows MELD's adaptability to new evidence, ensuring it remains relevant in 2025 and beyond. So, where does MELD shine in practice? Its flagship use in liver transplant allocation, directing deceased donor organs to patients 12 and older based on urgency, ensuring the highest risk individuals get priority. This system managed by OPTN allocates livers to those with greatest short-term mortality threat, reducing waitlist deaths. Beyond transplants, MELD assesses prognosis in chronic liver disease, guiding treatments like managing cirrhosis and complications. It also dynamic for monitoring. Scores 25 plus are recalculated weekly, 19 to 24 monthly, 11 to 18 quarterly, and under 11 annually, allowing real-time adjustment to care plans. In essence, MELD bridges lab data to life-saving decisions from ICU evaluation to global transplant networks. Understanding what MELD score means is a key to its power. Scores directly correlates with severity. A 6 to 9 suggests low risk, while 40 plus indicates critical illness. As shown in the table, 10 to 19 is the 6%, 20 to 29 jumps to 19.6%, 30 to 39 to 52.6%. For transplant, scores under 15 often shift focus to living donors as deceased donor weights favor higher scores. The US average at transplant is about 30. MELD sodium defines this by factoring sodium catching hyponatremia risk that amplify mortality. High predictive states like 72% sensitivity and 93% positive value, making it invaluable but always interpret alongside clinical context for holistic care. To wrap up, the MELD score is indispensable, evolving tool in liver disease management and transplant allocation, transforming subjective judgments into precise, equitable decisions. From its Mayo Clinic roots to MELD 3.0 advancements, it exemplifies medicine's commitment to data-driven progress. Yet challenges persist, like addressing sex disparities or regional variations, prompting continuous scrutiny and updates. Looking forward, as of 2025, expect more refinements, perhaps AI integration to further optimize outcomes and reduce waitlist inequities. Thank you for your attention, guys. I love to take questions. Feel free to reach via comments. Together, tools like MELD remind us of the impact we can have on patients' lives. Now, please like, share, and subscribe to the Docsaab's Diary.